Right. Good evening, everyone. Thanks for joining tonight, this evening. And my name is Abhishek. I'm one of the faculties with BitePACES. And today, what I'm going to do is I'm going to basically discuss about very common cases and questions which are very commonly asked to us, like in terms of what are the common things that we have like in the exam. I'm just trying to get the stuff up. Right. Is everyone able to see the whole screen of this thing? Okay, good. So first things first. We are today going to speak about the main common cases which comes up in PACES, and this is again to give you an insight about what you might expect in the exam. And I'm happy to take questions from you at the end of the presentation. That could be either in terms of through the audio things, if someone wants to unmute themselves, or in the chat. Feel free to ask me anything. It's not a very long webinar because it's just to sort of give you a flavor of what to expect. People who have actually appeared for these exams might have a bit of an idea, although my presentation again is catered to more who are sitting for the exam for the first time, and most importantly, people who are sitting in the UK. It again, for people sitting abroad, more or less these are the common things, but at the same time you need to keep in mind that certain countries don't have certain diseases. So I will, as I said, like it's a little difficult for me to understand which are the common cases in countries outside UK and the Indian subcontinent, because that's where I have graduated from and that's where most of my practice has been in. So yeah, let's go ahead. Right. So a couple of disclaimers that this is basically as per recalls from various candidates. And in terms of these things, it doesn't mean that you would get only these cases in the exam. You can get anything, honestly. And sometimes, like if your luck's bad, you might get one of the odd cases. But I have given these exams multiple times, and I've never got a patient outside the common ones, which I have been basically told by my seniors when they were sort of preparing me for the exam. Also, just keep in mind that if you are taking the exam, please do not, I mean, I know it's a very sort of common thing to do. It's a common temptation to do, that you go out and discuss the cases that you were in this center and this was this patient there. So if you're taking the exam, you are literally entering into a non-disclosure agreement with the RCP. So you are not allowed to mention which cases you had in the exam, because although again you might argue that no one's going to find out, but in case you are caught actually doing it, or someone, you never know, mentions about you that you have actually disclosed the cases, there have been incidents where exams have been cancelled for that candidate, leading to suspension. So do not do that. Again, there is no alternative to more and more practice and presentation to your buddies. That's the ideal thing. Although I do appreciate that sometimes getting study partners might be a little difficult for various circumstances, for various situations. So in those cases, and I'm one of them, like for one of my attempts, in these cases, it's basically you study it, look at yourself in the mirror and present. That is, if not ideal, that's close to ideal. As I mentioned, this is more relevant to the candidates taking the exam in the UK, but I'm not saying that this wouldn't be useful for candidates taking exams outside the UK, because these are more or less the rationale is more or less similar to what I'm about to discuss in irrespective of wherever you take it. So selection of cases, how the cases are selected. And the reason I've put in this slide is because a lot of queries come up in the WhatsApp group, actually saying, I have got exam in this particular center, any idea? I'm about to go into this particular country. Maybe it's Scotland, Edinburgh, Scotland, Wales, NI, you might get anywhere else in England. So literally any hospital, and most of these come up. So usually what happens is every center has its own patient bank. So it doesn't matter that if the hospital is treating a certain diagnosis, but say there was a patient of like, say for example, someone with a transplant has come into a center or being followed up at a center, which is a non-transplant center, they can be actually kept enrolled into the patient bank to come for the exam. So that is per se not particularly very helpful. Reassuring bit, usually stable patients are called and they have a clinical sign. So unstable patients would never come into the hospital. So you can be rest assured that they are the ones who have chronic diseases for a long time, compensated, but having good clinical signs to actually be examined and the candidate being assessed. But on certain days, patients drop out at the last moment. Can be multiple reasons. Maybe the weather is bad, maybe they are unwell, maybe they've got some family emergencies, or sometimes they just call up at the last moment and say, we are not coming, or I'm not coming. I just feel very, very tired. So they drop out at the last moment. And then what happens is then patients from a ward is wheeled down into the exam center, ones which are like sort of stable. So the max you can actually see is patients being on oxygen, but apart from that, like, you'd never get an hemodynamically unstable patient in the exam. Desperate time sometimes calls for desperate measures. You can get normal cases in the exam. Very, very funny incident. I have actually volunteered as an helper for PACES exam at one of the hospitals I've worked in, and we have been prepared for like a longer time just to sort of facilitate examiners coming in, get the candidates at the right place, make sure that the bell goes off at the right time. So these are basically the work of the volunteers. But so many patients dropped out that I ended up being called up at the last second to be a patient, and I ended up wearing a patient's gown and sitting there. As you can understand, if I was unwell, I would not have been volunteering. But because like they are so desperate, they just took me in as a patient. So I would not have any signs unless someone makes up a sign or I have an undiagnosed problem. But apart from that, just keep in mind that you can have normal patients, and often when you get normal patients, that is where, and you don't get any findings, that is where anxiety kicks in. And then some people get this temptation of making up signs, hearing things which are not there, seeing things which are not there. And please avoid this temptation, because that's the dark pit that you otherwise fall into. If you are found making up signs, that's a straight up fail. If you miss out a sign, okay, you get mark deduction, but making up signs is straightforward fail. So does the hospital play a role? As I mentioned, not particularly, because you never know, that hospital might have a patient who used to come to them 10 years back. They no longer follow up with the hospital, but they have just kept in the patient bank and they're just called up. I mean, the patients, when they're called up, they're paid a handsome amount to stay for the whole day, be examined by the candidates with breakfast and lunch and transport provided. So, I mean, who would want to avoid such an opportunity, isn't it? So, which is why, yeah, that is how it is. Now, I've divided the whole thing into system-wise things, and I'm going to go through every system, the most common cases that I have encountered. I have been told that they come, and as a volunteer, I have seen being appointed. So, but the cardiology, I'll start with cardiology because that's basically station one. So cardiology, very commonly, very commonly, you get valvular disorders. And when you get valvular disorders, you get most commonly aortic stenosis. Remember, in the elderly population, stenosis of the aortic valve is very common. So these patients are very stable. Maybe it's an incidental finding, but it's a finding per se. You can never miss out. They can never miss an aortic stenosis murmur, an ejection systolic murmur. So aortic stenosis very commonly comes up in the exam. Mitral regurgitation again is the next in line. You sometimes do get mitral regurgitation, and the third most common is tricuspid regurgitation, because you get a lot of people with heart failure, and that causes tricuspid regurgitation. Just to keep in mind for people sitting in the UK, mitral stenosis is very uncommon because it's mainly caused by rheumatic heart disease, which is very rare in the UK. I think in my 8 years of stay here in the NHS, I have come across only one, that too an incidental finding, and that too someone who's basically an immigrant, who's not actually from the UK per se. But for people sitting for the exam in the Indian subcontinent, very common. Rheumatic heart disease is very common there. So mitral stenosis per se is something that you would very commonly get. If now coming into the individual conditions, if you have got aortic stenosis, so as with any examination, start by inspecting very closely around the bedside, and then going and examining the patient, speaking with them, asking them to cough. So if you are going into a cardiology examination station, and then you are basically given the scenario that, okay, this patient has come in with shortness of breath, kindly examine and proceed henceforth. So, sorry, slides are not moving. Okay, are the slides still not moving? Oh, that's strange. Sorry about that. What about now? Oh, perfect. Thank you. Thanks for flagging it up. Right. So, yeah, there it is. So, as I mentioned, that with aortic stenosis, you see these patients and feel their pulse straight away. One of the very sort of good indicators is that when you start auscultating the heart, then the S2 might be very soft. And just keep an eye, just be very careful and be very sensitive in terms of if you can actually hear the S2 or not. Regarding the murmur, once you hear a murmur, I know under the exam anxiety, you can sometimes get confusion in terms of whether it's an ejection systolic murmur or a pansystolic murmur. Obviously, I have repeatedly asserted that you should not make up findings. You don't want to be doing a mistake. So I used to face this same conundrum, and what I used to do was, if I found a murmur, I straight away used to auscultate the carotids. Remember, with severe aortic stenosis, you can have radiation of the murmur to the carotids. And if you see there's radiation of the murmur to the carotids, you can be very well sort of confirm that it's an aortic murmur. Also, it is important to time the murmur. So if you are palpating the pulse and then listening to the murmur, so where it corresponds to is basically where the murmur is. So say, for example, going to the very basic concept of lub and dup, which we used to read in the physiology lectures, that lubs when the tricuspid and the bicuspid walls closed, and dup is when the semilunar walls or the aortic walls close. So that way you can actually differentiate as to what sort of murmur it is. With mitral regurgitation, remember, most of the patients would have atrial fibrillation, and they would also have a collapsing pulse. Very interestingly, when I see the candidates, practicing or examining patients at BitePACES, most of them do a collapsing pulse, but while presenting, they forget to mention about it. Remember, it's a very significant positive or negative finding. So you have to mention about collapsing pulse if you are thinking to present it on the lines of mitral regurgitation. Even if you think that the diagnosis is aortic stenosis, mentioning about the collapsing pulse gives you an important negative differential as to why it is not MR. Remember the MR for the pansystolic murmur. If you're looking at mitral regurgitation, radiates to the axilla. So if you listen to a murmur, just go down the axilla and see if the murmur basically radiates there or not. Tricuspid regurgitation, always remember tricuspid walls are the right-sided heart walls. So with all the signs of right-sided heart failure with raised JVP, you can sometimes get pulse-style hepatomegaly or really bad pedal edema. Now, realistically, I agree that if someone's got really decompensated heart failure, they would have pedal edema irrespective of which side of heart has failed. Now, as I mentioned, it is very, very unlikely that such unstable patients would be given in the exam because they have got really poor exercise tolerance. So it is, number one, impossible for them to come from their home to the hospital. And even if they're to take a patient from the hospital with decompensated heart failure, they are really unwell. So they would not take the risk of keeping this patient being examined all day in a non-acute setting. If you see a stable patient with raised JVP, pedal edema, and murmurs corresponding to like a tricuspid regurgitation, just go for the differential. $1 million question I had during my candidate life. People ask me, how do I understand, how do I actually distinguish the murmurs? Again, no alternative to practice, but at the same time, I would say YouTube has got a massive, excellent collection of these clips. Just at your spare time, keep on listening to these murmurs. I promise you, if you hear it at least 15 minutes a day for 7 days a week, you will be able to distinguish them. Personal experience, feedback from people, so you would definitely understand it. So the next thing comes up is if we are getting it in wall replacements. You can get wall replacements. Now, if it's a big, like if it's a metallic wall replacement, like for mitral walls, you will get sternotomy scars. Now, remember, these walls are either bioprosthetic walls or mechanical walls, metallic walls. So a very good approach is, remember, in the exam, everywhere your surroundings will be pin drop silent. Your examiners won't be speaking with you. There'll be no noise at all. So if you see a scar mark, the two things that you need to do straight away: first, look for vein harvesting scars in the legs. If you see vein harvesting scars, you know that scabbage might be a differential. If you don't see vein harvesting scars, it is possible that they might have a cabbage, but it would be the new technique with the lima bypass. But again, unlikely that these patients would come up in the exam. If next thing, just take consent from the patient, go near the patient, and then basically get your ear close to the scar and try to listen if you can actually get the click. If you get the click, you have got the diagnosis. Okay, there can be nothing else. That is your diagnosis. And the next step that you need to do is basically to time the click. Again, timing with the pulse is very important. That will help you differentiate whether it's a mitral valve replacement or an aortic valve replacement. But the moment, so that is how you sort of proceed with these patients. If you don't hear anything, it is and there are no vein harvesting scars, there might be a possibility, as I mentioned, that the new cabbages, or these patients might have a bioprosthetic valve. So both of these can be a differential. And if you tell it to the examiner that these are your findings and these are your differentials, you would not be penalized if you say both, because unless and until you do further investigation or you know the history, it is not possible to actually understand or know what the underlying diagnosis is. Remember, often there could be dual valve replacements and flow murmurs. So a very big temptation is the moment we hear the click or moment we get a diagnosis, we get too excited, and then we tend to forget that there could be something else also there. So time it with the pulse. If you see that both the click basically is a little faster than what it is usually, the time interval, and it corresponds with both off the pulse as well as with the pulse, then there is a very high chance that this patient is on has a dual valve replacement. Apart from that, remember, these patients, particularly with the metallic valves, they will be on anticoagulation. Remember the INR numbers, because that would be a question you will 100% be expected to answer, and you cannot get that wrong. Coming on to the next bit, again, the moment when you do the examination fully, you would then be expected to also mention about the fluid status. So if someone has got a valve replacement, you need to also include in the presentation that whether the patient is euvolemic or whether the patient is fluid overloaded. Okay, and that basically completes your examination or presentation. Someone's asking in the chat, can you repeat it? Which part do you want me to repeat it? Or I can actually answer your question at the end. So the dual valve thing. So remember, with the dual valve, when you palpate, when you hear the heart sounds or when you palpate the pulse, there is a certain interval. If there is a dual valve, so which means that there is an aortic valve and there is a mitral valve. So with the first heart sound, the mitral valve, the second heart sound, the aortic valve. Okay, now both of them doing at the same time. So like this. So remember, the click, the time interval between the two clicks would be much less in a dual valve compared to a single valve, right? So if you see that the time interval is less and it corresponds both with the pulse as well as without the pulse, that gives you an idea that it could be a dual valve. Coming on to the respiratory cases now. So very common, like I would say the number of candidates I have spoken with, the number of times I have given the exam, ILD has been the respiratory station for 98% of the patient, 98% of the candidates. So you cannot go wrong with ILD. ILD is a station. If this patient comes to you, you should be getting full 20 out of 20 in the station. So because findings are very straightforward, you cannot miss the findings. So you go in with the respiratory station, examine the bedside, ask the patient to cough. If they give a dry cough, you know for sure that it's not bronchiectasis. You're looking at a possible ILD or interstitial lung disease or something along those lines, but it's not like a lot of phlegm inside your alveoli. Definitely look for clubbing. ILD patients, interstitial lung disease or idiopathic pulmonary fibrosis will have clubbing. Auscultate, you will hear the fine and inspiratory crackles. Very important to say. So it's not enough to say, I cannot hear crackles. You have to mention this term, fine and inspiratory crackles. Assessing for fluid status or right heart failure, again, very important. Just like cardio station, respiratory station also. Remember, respiratory conditions, also, especially ILD, they also can give you some right heart failure. And they can make the patient's fluid overloaded. So it is important that you also mention about the fluid status, because as a clinician, these are the things you are expected to manage. And because the MRCP PACES exam or getting the full MRCP is a testament to the fact that you are now a safe medical registrar. As for a medical registrar, you have to go above and beyond what others would do. Excuse me. Similarly, with bronchiectasis, you would see sputum pot by the bedside when you examine the bedside. If you ask the patient to cough, a very wet cough, productive cough, and when you auscultate, they give you coarse expiratory crackles. Remember, if you are going down along the lines of bronchiectasis, then excuse me. If you're going along the lines of bronchiectasis, look at the table by the side of the patient. Often they do have pancreatic enzyme supplements by the bedside, and if you look at them, they will appear a little short-statured. Then go for, definitely strongly consider cystic fibrosis. The reason I have particularly put this up is because nowadays cystic fibrosis is becoming like really common in the UK, and a lot of hospitals are opening up dedicated CF units. So if you have got a CF unit, there is a very high chances that you get the patients from there. And CF, again, as you can understand, it's a very stable condition, but so many signs to actually pick up. So it's a very, 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 should I say, attractive and appealing case for the examiners or the lead examiner for that center to put up. So just make sure that you don't go wrong in this. Other things, again, theoretical wise, you can be asked questions about upper and lower zone fibrosis. You need to know this by heart. Features of life-threatening asthma. So say, for example, you get a patient who is wheezy. Your differentials could be possibly COPD, differentials could be possibly asthma. If you are presenting on the lines of asthma, then you would definitely be asked about life-threatening asthma, because again, this is a condition wherein expertise is usually expected from people working as medical registers. Other than that, scars, lobectomy, pneumonectomy. Remember, if you percuss, if there is no organ beneath, it can get a bit dullness underneath. So again, importance of vocal resonance becomes very is emphasized. Vocal fremiters nowadays is, again, some people do it, some people don't. With vocal resonance, if you do either of them because of the interest of time, then yeah, you basically can be marked on the basis of that. Patients with pleural effusion, again, is extremely rare because they have a lot of oxygen requirement, and they usually are not given in the exam. I can tell you, I think I can disclose this bit that I have never got pleural effusion in my exam because they are like really, they're really very unstable. Coming on to gastroenterology now. So for gastroenterology, again, the stations to score full marks on are if you get transplants. Now, these transplants could be either a liver transplant or a kidney transplant or a kidney pancreas dual transplant. Okay, very obvious. Liver transplant scar, you cannot mistake it. A rooftop incision scar, also called as the Mercedes-Benz scar. If you get really old patients like who has got liver transplants like ages back, there are certain hospitals like Royal Free Hospital in London used to do this previous big scar, which used to start all the way from the top and going down the right hypochondrial region. So that scar, again, you can confuse that scar with a gallbladder scar, but that scar is quite big. Like the liver transplant scar is really big. The gallbladder scars are no longer, they are not big if someone has an open cholecystectomy. So scars are very important. You have to mention the names of the scar. For liver, as I mentioned, once you look at the scar, once you know what you are dealing with, look for the signs of immunosuppression. Every transplant patient will have signs of immunosuppression, which you cannot miss. Nowadays, in terms of transplant drugs, tacrolimus is mostly used. We do not use cyclosporin much because of cosmetic problems. But again, knowing the side effects of tacrolimus or even cyclosporin is again very important because you can be asked in the exam and expected to answer. For kidney, understand the difference between a liver transplant and a kidney transplant is that, unlike the liver transplant, wherein you would not feel anything underneath the scar, for the kidney transplant, you will feel something beneath the scar. And once you know the diagnosis, just say the diagnosis first, straight away, because there isn't anything else. And if it's a kidney transplant, you will see other signs like, signs of previous VASCATs, previous permacats, signs of like AV fistula for hemodialysis. There can be scar marks of previous peritoneal dialysis with an entry and an exit port. So you have to mention everything of these things. And remember, it is not enough to mention that the patient has got a kidney transplant. You have to, particularly in this case, mention about the possible etiology. Now, remember, the main causes for kidney transplant in the UK is diabetes, glomerulonephritis, and hypertension. So with diabetes, you will find skin prick marks. With hypertensive nephropathy induced end-stage renal failure needing renal transplant, these patients are usually hypertensive. So when you basically start examining, when you're examining the pulse, a lot of you might be already doing it, but it's worth asking at this point, mentioning that at this point, I would like to take the blood pressure of this patient. Some of the examiners will then give you a figure. And that will say, for example, if the blood pressure is on the higher side, you probably know that, okay, hypertension might be the possible etiology for the end-stage renal disease. Again, mention about fluid status, very important, because a lot of transplant drugs may, example, cyclosporin or tacrolimus can make you retain fluid. Also, if your transplant's not working properly, you can start to get oliguria and start to accumulate fluid, resulting in peat edema, crepitations on the chest, and so on and so forth. So mentioning fluid status is very important. Once you sort of follow this particular proforma and this particular template and then present it, it is very unlikely that you would miss out anything in terms of what you need to tell to the examiner, and then questions would be asked to you accordingly. There are apart from the transplants, there are isolated patients, like you can only get like an isolated hepatomegaly and nothing else. you can get only a splenomegaly and nothing else. So again, one of if you get only a splenomegaly, there are other hematological conditions like some hematological problems like CML, um, and so on and so forth. You can also get, if you see signs of chronic liver disease, like stigmata of chronic liver disease, and you can't feel the liver, but you can feel the spleen. Remember, with liver cirrhosis with portal hypertension, you would get splenomegaly. So remember, with cirrhosis, unless it's amyloidosis driven, you usually get a shrunken liver. The cirrhotic liver is usually shrunken, so you would never ever be able to palpate the liver. So again, it's important to actually keep these things in mind. If you give a diagnosis of cirrhosis and you tell that you can actually palpate the liver, be a bit, double check that you are not palpating the abdominis rectus muscles and mistaking it for the liver. Look for jaundice, because that might be the only visible sign in the patient and nothing else. Again, you'll be asked along those lines in terms of prehepatic, hepatic, posthepatic jaundice. Stigmata of chronic liver disease, again, very, very important. You have to mention this statement while you're presenting these abdominal cases, that there are no stigmata of chronic liver disease, or there are stigmata of chronic liver disease in the form of maybe palmar erythema, spironevi, gynecomastia, painful gynecomastia, loss of hair, so on and so forth. Again, at the end of the day, completely normal patient with no findings. You can actually get it. I was the unlucky one with the last scenario. Neurology, again, commonly you get UMN and the LMN lesions. Remember the causes, again, very important. Don't forget to see scars. I remember, like, one of my patients had upper motor neuron lesions, and I was just about to say the wrong diagnosis when I noticed there is a when I moved the hair of the person, like he had short hairs, but when I looked closely with the pen torch, I could see a scar running down from there. So that sort of changes your diagnosis. Try to assess gait in the very beginning. Sorry. Yeah, try to assess gait at the very beginning, because often you might not get that time to do it at the end. Although some people tend to do it later in the exam. Remember, gait is a very important part of your exam, and unless the patient cannot walk or can actually establish that the patient's not safe to walk, or if the scenario is like the patient's feeling dizzy, you might go down that line and then say, you know what, I didn't feel safe to assess the gait of the patient, considering the scenario mentioned that the patient's dizzy. So that is an on-spot assessment that you have to do. Try to look for unilateral or bilateral signs. You can get bilateral upper motor neuron lesion signs in certain spinal injuries and things. Brown-Séquard syndrome is, again, quite commonly put in the exam. So yeah, so these are the things. You can get cerebellar lesions, so you cannot miss this out. Cerebellar lesions, there is a separate, like, chapter for cerebellar lesions. There is a mnemonic also. Just remember them and go for that. You cannot miss this ones. Quite straightforward to score marks. You can get neuropathy, so keep the differentials in mind: sensory neuropathy, motor neuropathy, sensory motor neuropathy. These particular cases can come anywhere in either station 1, the big examination bit, or can be put up in clinical consultations. Remember, Bell's palsy is, again, very commonly put up for clinical consultations, because it's very easy to impersonate someone with Bell's palsy and put in as a patient. Cranial nerve examination plays a very big role here, and be confident about about Bell's palsy, because it's a very unique thing. You probably would not get any other differential apart from other situations. No, I think Bell's palsy is like more or less, it's a very, very classical history if you're taking the clinical consultation station. Our next thing is Parkinson's disease. Again, the trick about Parkinson's disease, it's a very old patient. You see, as a Parkinsonian faces, they don't smile, they don't have much expression. And say, for example, if their hands trembling like this, you would usually sitting with the hand and another hand holding it like this. So you basically need to reveal the tremor coming up, and then see they're sort of doing it like this. Some people, like in their early stages, they can still withhold the tremor. So you then need to ask them, can you please count the months backward from December to January? So as the brain sort of gets occupied in terms of giving you the answer, that tremor is then uncovered. Remember, the differentials could be an essential tremor, like a pill rolling tremor and things. So mention these things in the site. If you are more or less confirmed that it's a Parkinson's disease, and if it's a clinical consultation station where you can ask questions, you definitely need to ask about whether are you struggling to read things, are you struggling to go down the stairs, or do you feel dizzy when you move around? Because there are other Parkinson's plus symptoms like multisystem atrophy and the other Parkinson's plus ones. Sorry, I can't remember from the top of my head. Progressive supranuclear palsy, PSP. So PSP and multisystem atrophy. So these are the two things that you need to sort of assess if you have sort of established that it's a Parkinson's disease. Again, gait is important. Get the patient to walk. Make sure once the patient stands up, hold the patient like this, and then ask the patient to walk. And you basically see short steps, initiation of movement, and then turning around and then walking towards you. In order to find out gait, again, take help from YouTube for various conditions. Lots of video resources available, and you can basically refer to that. Going to the communication station, only 4 scenarios which you can get. You will not get anything outside this. And nowadays, I understand with the new format, you are not asked any questions in the communication station. It's only you're assessed on your communication skills. It's either breaking bad news, wherein you basically break the news of like either their relative or themselves, like having an undiagnosed, like a chronic diagnosis, which could be a cancer-driven one, or a longer-term disease like multiple sclerosis, wherein there would be significant impairment in the quality of life, or motor neuron disease, wherein they slowly lose their swallow and they would need pegs to be put in for feeding. Establishing ceiling of care, again, common things. I understand people who are working in the UK, even like as a JCF or IMTs, you have had multiple of these discussions. Counseling about organ donation, again, you need to understand what are the laws and rules surrounding organ donation, and again, doesn't necessarily come up much, but you might get it. Most commonly, it's dealing with an upset or an angry next of kin. I would particularly want to stress upon this scenario that also the first scenario. So I'll say with dealing with an upset and an angry next of kin, remember some of these people who are coming for these scenarios have been doing it for years and years. And so they want to perform the best they could. So I remember like one of my exam, I was dealing with an upset relative, and she was literally shouting at my face, banging the desk like this, though she was like overacting. But these can, on an exam anxiety situation, have a massive impact, especially if you're sitting for the exam for the first time. So just if you suddenly feel taken aback by these actions, just calm yourself down and then start speaking again. Do not retaliate. Do not raise your voice. That will carry mark deduction. I know human nature, we will do it outside, but don't do it in the exam. With breaking bad news, Again, probably none of you would do it, but again, these are the actors who, like, they're like, they have been doing it for years and years, and some of them are so sincere towards their role because they are paid and all of these facilities, that they carry glycerin for themselves, like glycerin or other things for them, so they actually cry, or they actually can cry for that moment and just for the show. I was being told that one of the actor was so much into her role that as the bad news was broken to her in terms of her son would not survive the accident, she started to cry, and the candidate opposite started to cry too. Do not do this. Very unprofessional. As I said, I don't think anyone would do this, but certain candidates have actually done this, and again, that's a fail. So do not do this. Just compose yourself, calm yourself down, and speak slowly, steadily. Allow the person opposite you to sort of actually absorb what you're taking, process what you're taking, give information in like short packets, and yeah, you should actually get full marks in this station if you do it properly. Needs a lot of practice, so this is where study buddies come handy. I'm sure if you are in a hospital, you can do communications practice with someone at least. And with this, I come to the end of my slides. I have purposefully omitted clinical consultations from my lecture today, just because I am aware that a similar webinar happened last week with Dr. Vishnu, who has done a very, very good job. So I would probably not intrude into his territory and just cover the rest of the bits. And I'm happy to take questions. So feel free to unmute yourself, feel free to type, and I can then answer. So certain questions which came up: bronchiectasis, obstructive or restrictive? My understanding, as far as I remember, I think it was obstructive, but don't take me into it, because it's been a while I've given the exam, so do I know how bronchiectasis is managed, but I cannot give this thing the answer. Hepatomegaly in cirrhosis. Yes, you can get hepatomegaly in cirrhosis if you have an amyloidosis induced liver damage. So yes. Is there a station for musculoskeletal? Musculoskeletal will usually come up in the clinical consultations, mostly. Neuro examination, I have very rarely seen musculoskeletal questions come up. Abdul, neuro-ophthalmology, fundoscopy. Fundoscopy, I would say 50-50. Might come, might not come. What are the signs you would expect to see in a case that came later as emphysema? Isn't it a pathological? In a case that came later as emphysema. Well, I mean, emphysema is the end stage of COPD, isn't it? So you would get V's as well as reduced movements. So yeah, the usual signs for obstructive lung disease. Do we need to present upper lobe fibrosis as ILD or a separate entity? I mean, to be honest, if you hear those things again, if you hear those signs, like you see, you got fine end inspiratory crackles and dry cough, you can always present it as an ILD thing. Dr. Aslam Khan Ibrahimizai, so is there a way to know about common cases coming in your exam center? You already have a lot of, I mean, there is a way you can always find out, but I have never done this, and I always discourage people from doing this. You don't want to go into that anxiety. You already have PACES is a very preparation for PACES will give you a lot of anxiety, no matter whatever I say. So you don't want to be taking extra anxiety. So just prepare the basics, just do your basics, and take it as and how it comes. I don't think knowing about the common cases coming in your exam center is anything important. There are book or list to practice for consultation cases. So I think in terms of book, BitePACES does, if you register with us, you would be given a handbook with all the candidates are given, but I would let Dr. Shoaib Siddiqui or Usman Ahmed to answer this if you're in the group. And they should have consultation cases. Apart from that, the writers' books, like the Oxford publications writers' books, they have a lot of clinical consultation cases which you can basically go through and practice. Exhaustive, like a lot of cases, if you've got time, you can and if you've got a study partner, just sit down and do this consultation cases. Yeah, and the writer books are really good. Any advice on how to best structure the response for clinical stations? Well, depends. Different people have different approaches. I tell to people that if it's a transplant case and you know that the diagnosis can't be anything else apart from that, just go in with the diagnosis first. But if you've got any doubt about the diagnosis, just say the positive findings, relevant negative findings, and then just give your differentials. Anpu, can we get the handbook for BitePACES before and if courses near to the exam? Yes, Anpu, if you just if you have registered for the upcoming courses and you can just put a message in the group, and Shoaib or Usman would basically get back to you. My understanding, because obviously I'm just a faculty member, I don't share this thing, but I'm sure they would give an answer to your question, and you should be able to get the handbook. Any further questions? If you cannot attend the course, I mean, the handbook is basically given as a part of your registration to the course, my understanding. So I'm not, and it's not out for formal publication yet. So I don't think don't take my word for it. But again, feel free to message in the group. But my understanding is if you do not attend the course, you do not get the handbook. I mean, it's basically an ebook format sent by email. So yeah, that is how it is. But as I said, feel free to message in the group, and one of the course organizers, either Dr. Shoaib Siddiqui or Usman Ahmed, will get back to you about it. Right. So anyone has got any questions? I have attended for one day. Okay. So if you just okay, if I can. Okay. Again, I think probably these questions are best if you are in the BitePACES group. Just put this question up there, and yeah, you would be reverted back. Because I don't think Dr. Siddiqui is currently seeing the seminar. So yeah, if you just put it in the group, or I think it's a more or less common theme. So I will put this question in the group, maybe, and then see what others say. So from the questions bit, any advice on how to best structure the presentation response back for clinical stations? I mean, as I said, like you can either there isn't any particular template to do this. If you are working in the UK, it's mostly like how you present patients for post taking. Mainly, it is you start with, okay, upon examining the patient, he or she appears comfortable at rest. If you see anything in the bedside, I can see this particular thing in the bedside. And then going further up, the pulse is regular, beats 80 beats a minute, no collapsing pulse. And then you go up, like depending on what station you're presenting. There isn't any, so the template's different for different stations. Right. So if people don't have any further questions, I would then probably call it a day. Leave you for the rest of the evening. Thanks for attending. Hope you found it useful. And people who have signed up for the upcoming courses in May and June, I will see you there. Hopefully able to help you guys clear the exam. But any other questions you might have from today, yeah, please feel free to put it up in the group, and I will get back to you as soon as possible. Thank you.